Good morning, everyone. Today I'm presenting a 2017 paper titled The Influence of Hormonal Contraception on Vitamin D Supplementation on Serum 25-OH Status in Premenopausal Women. This is a prospective, double-blind, placebo-controlled randomized trial that addresses a really important question in female physiology. Does the use of estrogen-containing contraception alter how a woman's body responds to vitamin D supplementation? This study builds directly on observational findings we saw in a previous presentation on winter versus summer vitamin D levels in dancers. Let's start with what we already know about this study. First, we know that vitamin D insufficiency is a global problem with serious consequences for bone health, immune function, and even muscle performance. Second, several observational cross-sectional studies have noticed something interesting. Women taking the estrogen-containing contraceptive pill had significantly higher serum vitamin D levels than women who weren't. Harris and Dawson-Hughes, for example, reported levels up to 39% higher. Two main mechanisms were proposed to explain this. One is that estrogen might increase the activity of the liver enzyme that performs the first hydroxylation step, turning vitamin D into 25-OHD. The other, perhaps more plausible, that is that estrogen increases the production of vitamin D binding protein, VDBP, which binds the vitamin D in the circulation and increases its measured total concentration. But here's a critical gap. All of this evidence was observational. No one had done a prospective randomized control trial to see if women on their pill actually responded differently to a standardized dose of vitamin D. And that's exactly what this study set out to do. So we designed the study. It was a prospective, double-blind, placebo-controlled randomized trial, the gold standard for this type of question. We recruited 38 premenopausal women from a university campus in the UK. The study took place in March, which is important because sunlight hours were limited and with only about 125 hours over the 4-week study period. This minimizes the confounding effect of sun exposure. The exclusion criteria were carefully chosen. We excluded anyone already taking vitamin D, anyone who had started or stopped the pill in the last 6 months, and anyone using other forms of contraception like implants. This ensured that we had clean groups, stable pill users versus non-users. The intervention was a high-dose bolus, 100,000 international units of vitamin D3, taken over 3 days. The placebo group received identical inert tablets. Randomization was a 1-to-1, handled by an independent technician to maintain blinding. Let's look at the variables and the methods. The independent variables were straightforward. Contraception use, yes or no, with a minimum of 6 months on an estrogen-containing pill, and supplementation, vitamin D, or placebo. The dependent variable was serum 25-hydroxy vitamin D, measured before and 4 weeks after the intervention. A really nice feature of this study is the blood collection method. We used capillary blood spot sampling, a simple finger prick. This is much less invasive than a venous draw and is ideal for studies like this. The samples were analysed using LC-MS and MS, and this is a gold standard for vitamin D quantification at an accredited laboratory. This gave us 4 groups for comparison: women on the pill who got vitamin D, women on the pill who got placebo, women on the pill who got vitamin D, or women not on the pill who got vitamin D, and women not on a pill who got placebo. Now let's look at the results, and they're quite striking. At baseline, women on the pill did have higher vitamin D levels, about 11% higher. But this wasn't statistically significant, so they started with a similar place. The ANOVA analysis revealed 2 key things. First, there was a highly significant 2-way interaction between supplementation and time, which simply confirms that vitamin D supplementation worked. It raised levels. The more interesting finding was a significant three-way interaction between contraception, supplementation, and time. This tells us that the effect of supplementation was not the same for both groups. Looking at the numbers, in the women not on the pill, vitamin D supplementation increased their levels from about 44 to 70 nanomoles per litre, a very respectable increase of about 25 nanomoles. But in the women on the pill, the increase was from about 46 to 98 nanomoles per litre, an increase of over 52. That's double the response. The difference between these two groups was statistically significant, the p-value of 0.019. This figure brings the data to life. On the left, you can see the pre and post values for the placebo groups. As expected, they're essentially flat, no change. In the middle, we have the women not on the pill who received vitamin D, and you can see a clear, significant increase from pre to post intervention. We look at the far right and the women on the pill who received vitamin D. The increase is dramatically larger. The post-intervention mean is approaching 100 nanomoles per litre, which is considered an optimal level by many standards. This visual really drives home the point. The pill doesn't just slightly enhance the response, it appears to amplify it substantially. Women on contraception got twice the benefit from the same dose of vitamin D. So how do we interpret these findings? First, this study provides causal evidence for what was previously just an observation. The pill does, in fact, influence vitamin D metabolism. Second, the magnified response to supplementation, a doubling of the increase, is a novel finding. It strongly suggests that the mechanism we discussed earlier are at play. Where there's increased liver enzyme activity, or more likely increased vitamin D binding protein, the result is the same, the higher measured total serum 25-OHD. The authors raise a really important and nuanced question. Is this increase in total 25-OHD actually translating into more bioavailable active vitamin D at the tissue level, or is it simply more bound vitamin D sequestered on binding proteins and physiologically inactive? This is a critical point. If we use total 25-OHD as our clinical marker, and we do, we might be overestimating the true vitamin D status of women on the pill. They could have higher total levels, but still be functionally deficient in free active hormone. This is a hypothesis that needs testing. So what are the takeaways? First, the conclusion is clear. Estrogen-containing oral contraception significantly increases serum 25-OHD levels in premenopausal women. And this effect is markedly magnified when combined with high-dose vitamin D3 supplementation. This has two major implications. For research, it means that contraceptive use must be considered a confounding variable in any vitamin D study in women. If you don't count for it, your data could be misleading. For clinicians, it means that when you're interpreting a serum 25-OH result for a female patient, you need to know if she's on the pill. The normal range might simply be different for this group. This study also points to several clear directions for future research. We need studies that measure not just 25-OHD, but also free 25-OHD, 1,25-dihydroxyvitamin D, PTH, and bone turnover markers to understand if this increase in total levels translates to real biological effect. We also need to look at other estrogen-altering states, like HRT in postmenopausal women, or even the natural hormonal changes during menarche and menopause. The limitations are the small sample size and the short duration, but within these constraints, this is a well-designed study that answers an important question and raises even more interesting ones for future work. Thank you for listening. This ends the series on vitamin D and dancers. If you have enjoyed listening, please listen to some of the other studies we have done at the University of Wolverhampton in collaboration with our colleagues.